Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I would like to discuss fluid therapy on intensive care unit. It is a broad topic actually, and I would like to focus on the overview of the fluid therapy here. First of all, I would like to start with the pathophysiology of fluid in the body. Normally, in a 70 kilo person, 60% of their body weight is water, which is about 42 liters. Out of 40 liters, about 25 liters, which is 40% of the body weight, is intracellular fluid, and 15 liters, which is about 20%, is extracellular fluid. Out of 15 liters, 10 liters is interstitial fluid, 5 liters is intravascular fluid. The main contents of intracellular fluid, which involved in distribution of body water, are potassium, phosphate, and intracellular protein. And those of extracellular fluid are sodium and chloride, and also albumin mainly in intravascular fluid, and collagen mainly in interstitial fluid. Here, I would like to explain the factors influencing the mechanism of fluid shift between vascular and interstitial spaces. Physiologically, there are two factors pushing fluid out of the vessels into interstitial tissues, which are vascular permeability and hydrostatic pressure. Plasma oncotic pressure is the ability of plasma proteins to bind and retain water in the circulation. 75% of the oncotic pressure effect is due to albumin. The rest is due to hemoglobin and globulins. In critically ill patients, for example in sepsis, inflammation increases vascular permeability and leakage of plasma protein. Albumin leakage is increased up to 3 times that of normal leakage. Acute illness also impairs hepatic albumin synthesis, reducing total albumin by about 15 grams per day. These combined factors lead to reduced oncotic pressure, so water in vascular space shifts into interstitial fluid. This causes intravascular hypovolemia and interstitial edema, such as peripheral edema, gut edema, which could cause malabsorption, and pulmonary edema, which could lead to impaired gas exchange. In patients with congestive heart failure, that vicious mechanism is enhanced by increased hydrostatic pressure, resulting in more fluid shift into interstitium. Most of the patients who require fluid therapy are associated with shock, which means the blood flow to major organs is poor. When renal blood flow is compromised, renal angiotensin-aldosterone system is stimulated, as well as antidiuretic hormone is released. Both could concentrate urine by retaining sodium and water from renal tubules, and the urine output and excretion of solute loads, urea for instance, could be significantly reduced. In addition to hormonal response to stress, initial fluid resuscitation with high sodium containing fluids could also worsen the already struggling renal function and body fluid homeostasis. Moreover, during critical illness, due to impaired energy, which is ATP production, and consequent failure of sodium-potassium ATPase pump, intracellular sequestration of sodium and water could occur, leading to cell edema, which is known as sick cell syndrome. Now, we can briefly see the manifestation of how fluid shift works during illness. Next, I would like to talk about daily requirement to guide fluid therapy on ICU. In a 70 kilo person, normal daily water requirement is about 1.5 to 2.5 liters, which is about 25 to 35 ml per kilos per day, to cover physiological losses from the body, which I'll explain in a minute. We should consider lower volumes around 25 ml per kilo per day in older or obese patients and those with renal or cardiac impairment. Daily sodium requirement is about 70 to 100 millimole, which is about 1 to 1.5 millimole per kilo per day. Potassium about 40 to 70 millimole, which is about 0.5 to 1 millimole per kilo per day. And glucose about 50 to 100 grams per day. Normally, water and electrolyte losses can occur in urinary tract as urine and GI tract as feces, and also as insensible losses via respiratory tracts as lung water vapor and via skin as sweat. If a patient is having diuretics or renal problems, for example polyuria, electrolyte losing nephropathies, diabetic nephropathy, or having abnormal fluid losses via GI tract like vomiting, diarrhea, fistula, or high output ileostomies, or having increased insensible losses in conditions such as tachypnea, burns, trauma, fever, high ambient temperatures, there will be higher fluid and electrolyte losses from the body. In these scenarios, water and electrolyte homeostasis is further complicated, and fluid prescription could be quite complex, especially in patients with intravascular deficits with tissue edema. It is crucially important to assess fluid status of a patient before we prescribe fluid therapy. If the patient is conscious, we can simply ask if they're thirsty. Moreover, we can examine the skin turgor, any peripheral or dependent edema, any lung crackles, and check the vitals such as blood pressure, heart rate, capillary fill time, respiratory rate, and body temperature. We can also have a look at blood gas for pH, base excess, and lactate, and also lab tests for hemoglobin, hematocrit, urea, creatinine, sodium, and other electrolytes. As a bedside test, we can do TIL test, which is passive leg raising test, to see if it is positive, which means the patient is potentially going to respond to fluid bolus. Although this test is limited by a few factors, it is non-invasive, free, and quite reliable, so it is widely used on intensive care units. We can also observe swings in the R-line tracing to predict fluid responsiveness. However, it is not a very accurate method. Furthermore, we can calculate cardiac index, intra and extravascular water via cardiac output monitoring by pulse control cardiac output PICO studies. If you'd like to know more about passive leg raising tests and PICO, please let me know in the comment section, and I'll make a separate video to explain it as much as I can. Focused intensive care echo (FIScan) could be quite useful to assess fluid status as well. To understand daily fluid balance of the patient, we should monitor intake and output of the patient closely on ICU observation chart. For example, fluid intake via infusions and feed, output via urine, NG, stoma, drains, etc. Serial measurement of body weight together with daily fluid balance monitoring is helpful in patients with ascites, chronic kidney disease, and heart failure. If the patient is appropriate for fluid therapy, we need to bear in mind that fluid is best delivered by enteral route, which is oral, or nasogastric route, but intravenous IV fluid may be needed in patients who are acutely unwell and require resuscitation, who have excessive fluid losses, patients who are unable to drink, for example due to coma or unsafe swallowing, or unable to absorb like in paralytic ileus. IV fluid prescriptions should include the type, volume, and rate of fluid to be administered, and frequent reassessment of patients' fluid status is necessary. The choice of fluid is determined by fluid and electrolyte requirements depending on pathology. We should stop IV fluids when patients are clinically stable and able to tolerate oral or enteral fluids. The types of fluid which we could provide are crystalloids, colloids, sodium bicarb, and technically blood as well. In this video, I will not discuss blood and blood products. That topic is for another video. What are crystalloids? They include balanced crystalloids, for example, Hartmann solution, Ringer lactate, saline, such as 0.9% normal saline, 0.45% half-strength saline, and 3% hypertonic saline. Glucose, like 5%, 10%, 20%, or 50%. Colloids include albumin, for instance 4.5 or 20% human albumin solution, dextran, gelatin, and hydroxyethyl starch. For sodium bicarb, we can use 1.26% or 8.4%. Now, I would like to discuss indications and risks of common types of fluid. First of all, let's talk about Hartmann solution, which is balanced crystalloid and probably the most popular fluid used on intensive care unit. 1 liter of Hartmann's solution contains an estimate of 130 mmol sodium, 5 mmol potassium, about 30 mmol of bicarb, 110 mmol of chloride, and 2 mmol of calcium. It can be used for fluid resuscitation as IV bolus in hypovolemic patients, or for IV maintenance fluid in patients, for example, who are kept nail by mouth or whose oral intake is poor. The risk of Hartmann's solution is fluid overload in patients with underlying heart failure and anuric renal failure. Not quite 9% normal saline consists of only 154 mmol of sodium and chloride per liter without any other electrolytes, so actually it's not normal or balanced at all compared to Hartmann's solution. We can use saline to correct hyponatremia, for preparation and dilution of drugs or IV infusions, in arterial or central line transducers, to flush lines and cannulas, and as nebulizers to help with respiratory tract secretions. Hypertonic saline can be used in neurotrauma patients with increased ICP and to correct severe hyponatremia presenting with seizures. Saline can be used during IV fluid resuscitation. However, there is significant risk of hyperchloremic metabolic acidosis due to high sodium and chloride loads, leading to problems with coagulation and renal function. Moreover, rapid correction of sodium could occur, especially with hypertonic saline, and it could be complicated by central pontine myelinolysis due to rapid osmolality change and water shift out of intracellular space. Fluid overload is quite notorious side effect in patients with congestive heart failure due to high sodium content. Glucose or dextrose solution simply contains glucose and water in it. It can be prescribed to treat patients with hypoglycemia, 50% as IV bolus and 10 to 20% as IV maintenance infusion to prevent rebound hypoglycemia. Dextrose is also useful in treating DKA patients when blood sugars start to fall below 40 mmol per liter, and diabetic patients who are nail by mouth and on insulin infusion. We can use 5% dextrose in patients with hypernatremia or to prevent rapid rise of sodium when treating hyponatremic patients. Furthermore, dextrose can be used for preparation and dilution of drugs. Please bear in mind that when we give glucose to a patient, we should keep an eye on blood sugar as well as sodium level. In colloid category, apart from human albumin solution, Hess, The rest are not used anymore due to risks of dilution coagulopathy and nephropathy. We can consider using 20% albumin after multiple crystalloid boluses in patients who are still hypotensive with sepsis, where crystalloids may not be useful due to high vascular permeability and reduced oncotic pressure, as I explained above. However, recent studies suggest the morbidity and mortality benefit of albumin is not superior to that of crystalloids in septic patients, so it could not justify the expense of albumin. Personally, I would recommend balanced crystalloids as first line for fluid resuscitation, and if there is no response, then I would probably try 20% HAS. On intensive care units, we don't tend to use 5% HAS due to higher sodium load and lower albumin content, hence it is not as efficient as 20% HAS. Lastly, I would like to talk about sodium bicarb. 1 liter of 1.26% sodium bicarb include 150 millimole of sodium and bicarb, and in 8.4%, 1000 millimole of sodium and bicarb. Usually, we use 1.26% sodium bicarb to correct metabolic acidosis and hyperkalemia in renal failure, and to replace bicarb loss, for example in renal tubular acidosis, diarrhea, and fistula. In life-threatening drug overdose, for instance TCA or salicylate overdose, and cardiac arrest or peri-arrest with severe metabolic acidosis, higher concentration, 8.4%, can be used. The well-known risks of excessive administration of IV sodium bicarb are fluid overload due to high sodium content and paradoxical intracellular acidosis. Here, I'd like to explain the mechanism briefly. IV bicarb that we give will bind hydrogen ion and form carbonic acid, which will dissociate into CO2 and water. The increased CO2 will cross cell membranes via simple diffusion, resulting in intracellular acidosis, as bicarb normally cannot cross cell membrane. For that reason, we should consider increasing the minute volume in mechanically ventilated patients for CO2 washout. In addition to intracellular acidosis, management with bicarb could decrease in plasma ionized calcium as a result of alkalinization, leading to decrease in myocardial contractility. Also, bicarb could shift the oxygen hemoglobin dissociation curve to the left, which means the affinity of oxygen and hemoglobin becomes higher, causing decreased tissue oxygen availability. Therefore, sodium bicarb is inappropriate when tissue hypoperfusion or necrosis is present. This is a bit overview of the fluid therapy in critical care. Hopefully, this video is useful to you. If it is, please share with your friends and colleagues. I'll see you in the next video. Take care.